Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today we will talk about a disease which most of you will come across in your practical and professional life, whether you are working as a medical officer on general duty or in any emergency room or as a pediatrician or as an ENT specialist. You will face a handful number of such patients. So let's start it. This is what I am referring to is called as acute suppurative otitis media. So as the name indicates, this is an acute inflammatory disease and it is defined as suppurative infection or inflammation of the mucoperiosteal lining of the middle ear cleft. There are two words which are very important in this statement. One is mucoperiosteal layer, because until and unless the infection is confined to the mucoperiosteal layer, it is not complicated. Once the infection has gone beyond mucoperiosteal layer, and beyond mucoperiosteal layer is the bony confines. So once the bone is involved, then the disease has become complicated. And which mucoperiosteal layer? That is the middle ear cleft. And what is a middle ear cleft? In next slide I will refer to. Now there is a clinical classification for any disease depending upon the duration of symptomatology. If any symptom is there within last 3 weeks duration, we call it as acute. But if symptoms are there from last 3 weeks to 3 months, then the disease is called as subacute. And if any symptom it is there for more than 3 months or 90 days, then the disease is labeled as a chronic disease. In pathology, there will be different explanation for these acute, chronic, subacute diseases depending upon the infiltration of different cells into the tissues after histopathological examination of those tissues involved. So acute suppurative otitis media will be that the duration of the symptoms will be there less than 3 weeks. Recurrent acute otitis media. Recurrent is the disease that there will be episodes of manifestation of the disease, but in between episodes the patient will absolutely be all right, free of symptoms. We label it as recurrent acute otitis media if there are 3 episodes of acute otitis media in last 6 months, or in last 1 year there are 4 episodes of acute otitis media. Now, as in the definition, we mentioned that this is the inflammation of middle ear cleft. So what do we mean by middle ear cleft? Now, middle ear cleft, it consists of, or it includes this eustachian tube, that's also called as pharyngotympanic tube. Then is the middle ear cavity or tympanic cavity. Then is AETIOLOGY, through which this tympanic cavity is connected with the mastoid antrum and mastoid air cells. So all these structures, they are included in middle ear cleft. On the left side, the picture is showing normal middle ear. This is the tympanic membrane. and the ossicles. This is the Eustachian tube. On the right side, it is inflamed middle ear cleft. There you can see congestion of the tympanic membrane. Then there is infected fluid in the middle ear cavity. And this is the Eustachian tube. You see, due to mucosal edema, it is almost completely occluded. It usually is seen in pediatric population during winter and spring seasons, usually preceded by upper respiratory tract infections. Then measles, diphtheria, repeated tonsillitis, chronic infection of sinuses, and nasal allergies are also other predisposing factors. Causative organisms, the bacteria which are involved includes, in more than 30% of the cases, Streptococcus pneumoniae is the culprit. In 20% of the cases, Haemophilus influenzae, then Moraxella catarrhalis, and even Streptococcus pyogenes, Staphylococcus aureus, and Pseudomonas aeruginosa have also been cultured. In roughly 20% of the cases, there may be no growth on culture, and then certain viruses can also cause, because otitis media usually is preceded by upper respiratory tract infection, which is usually to start with is viral infection. So respiratory syncytial virus, RSV, influenza, rhino and adenoviruses can also be involved in the causation. From this slide, you can very well imagine that Streptococcus pneumoniae and Haemophilus influenzae collectively, they are the causative agents in more than 50% of the cases. So these are the major organisms which are causing this acute otitis media. From where the infection can go to the middle ear, there are three possible routes. The most common route is Eustachian tube, because from our knowledge of anatomy, we know that middle ear cleft is a closed structure which is exposed to the atmospheric air only through the Eustachian tube opening in the lateral wall of the nasopharynx, from where the atmospheric air can go into the middle ear cleft. So the source of infection or route of infection will be that the bacteria will be coming from nasopharyngeal end of the Eustachian tube. So that's why it is usually preceded by upper respiratory tract infection. Then another route can be external auditory canal, but with the condition that already due to some other disease or trauma, there is a perforation in the tympanic membrane, unhealed perforation you can say. Then the infection can enter in the middle ear cleft from external ear. And the third possibility is that blood-borne infection, that there is some source of infection in the body anywhere, maybe distant from the ear, and septicemia occurred, and through the blood the bacteria traveled to the middle ear. Theoretically, yes, there is a possibility, but practically it is very uncommon route, because the blood supply of the middle ear itself is very scanty, and in the body there are so many other organs and tissues which have got a very rich vascular supply. So if any infection has to travel through blood and have to settle somewhere in the body, it will be settling in those areas which has got a rich blood supply. So keeping in mind these three routes, let's talk about this Eustachian tube, which is the most common route for the causation of this acute otitis media. Children are more susceptible As I told you, it is more common in pediatric population. Why? Because there is a difference of eustachian tube anatomically from adult eustachian tube. In children, this pharyngotympanic tube or eustachian tube, it is shorter, it is wider, it is more horizontally placed, it is less stiff, and there is no isthmus. Then we know that in children there are adenoids which are present in the nasopharynx in the neighborhood of the eustachial tube opening. So they can mechanically obstruct the opening of the eustachian tube, or if they become inflamed due to repeated adenotonsillitis, then the infection can travel through the eustachian tube to the middle ear. In children, of course, immune system is not that much well developed. Eustachian tube, from your knowledge of anatomy, you know that it has got an osteocartilaginous framework, and it is connecting the middle ear to the nasopharynx, and its functions are, main function is aeration of the middle ear cavity, because the middle ear cleft is only exposed to atmospheric air through the eustachial tube opening into the nasopharynx. Then middle ear, it is lined by the mucosa. It is containing mucus and serous glands. So those secretions are being drained by the eustachian tube into the nasopharynx, from where these are being swallowed. So it prevents the fluid retention there in the middle ear, because wherever there will be retention or stagnation of the fluid, there are chances of infection. And in adults especially, because it is obliquely placed, so it protects against the nasopharyngeal infection from traveling to the middle ear. And in the picture, it will be more clear, which I just talked about, that this is a child or an infant on the left side, this is an adult on the right side. In pediatric group, you can see that this is the eustachian tube, which is more horizontally placed as compared to adult, where it is slanting upwards at 45-degree angle. So it is obliquely placed. Then there is no isthmus in children. Isthmus is a natural narrowing which is present in the adult eustachian tube at the osteocartilaginous junction. So it is absent. So any secretions, they can, infected secretions from the nasopharynx or the bacteria, they can travel up to the middle ear. External acoustic meatus, as I told you, is another route. There may be possibility, but it is only when it is associated with tympanic membrane perforation already. That perforation may be due to trauma to the tympanic membrane already, or some surgery like insertion of the grommets was there, and later on there is residual perforation, or during tympanometry there is trauma to the tympanic membrane or myringotomy, or like this. And then bloodborne, I already have discussed about this, that this is theoretically okay, but otherwise this is an uncommon route as far as the middle ear infection is concerned. So predisposing factors, now you can very well imagine that age, pediatric population is more prone to get it. Socioeconomic factors, then climate, then urban population because of pollution and repeated upper respiratory tract infections. Anatomically, you know, eustachian tubes, adenoids, nasal polyps, sinus infections, and then allergic rhinosinusitis, etc. can play a role as a predisposing factors. Upper respiratory tract infections, if repeatedly are there, then allergies, craniofacial abnormalities, especially in cleft palate, for example, then in Down's syndrome. And those children who do passive smoking, they are more prone to get this infection. This is the X-ray nasopharynx lateral view, and if you closely observe, you can see in the red arrow, there is a soft tissue, soft density mass which is compressing the air column, which is marked by this blue arrow. From below you see so much wider air column, but here it has become so much narrowed. So this is more probably this is a adenoid hypertrophy. Then there are some genetic predispositions also, for example, Eustachian tube dysfunction, allergic tendencies. Then if in first 3 months after birth, if the baby is on this bottle feeding instead of breast milk, they are more prone to get, because breast milk contains lactoferrin, oligosaccharides and surface immunoglobulin A that inhibit the bacterial colonization. And then sucking generates negative pressure in the nasopharynx. So it sucks out the secretions and some fluid even like milk, and then along with that there can grow bacteria later on. And incorrect posture while feeding, because the baby should be fed in upright position at 45-degree angle, but usually with bottle feeding especially, what the mothers do, that they give the baby bottle and then they lie him on his back straight. So that is the incorrect posture, as a acting as a predisposing factor for the causation of infections in the middle ear. So while attending the classes, this is the main aim in our system. Now this is very important to understand that what is the pathophysiology of this disease, because if you understand this pathophysiology, the signs, symptoms of the disease and its treatment will be very easy. As we have seen from the previous slides, that Eustachian tube is the main causative factor in the causation of this disease. So first of all, there will be stage of tubal occlusion. That tubal occlusion may be due to inflammation, or that may be blocked by the adenoid hypertrophy, or any other disease there in the nasopharynx. So to start with, it will be a stage of tubal occlusion, and that tubal occlusion will lead to the hyperemia or congestion of the mucous membrane of the middle ear cleft. Next stage will be stage of pre-suppuration. That any inflammation, when it starts with transudate. Still pus has not formed, but fluid is there, increased amount of fluid which is transparent. So this is a stage of pre-suppuration. If the disease is not heralded here at this stage with the proper treatment, it will progress to what it is stage of suppuration. Means now transudate has been converted into exudate. Now the pus has been formed. So you can very well imagine that from stage of tubal occlusion to stage of suppuration, the disease is progressing from mild to severe form. And once at the stage of suppuration, there are two possibilities. Either with treatment or with spontaneous outcome of the disease, there will be a stage of resolution. Or there may be the disease can go into stage of complications. So keeping in mind all these stages, let's discuss the principle behind their causation and how the patient at the particular stage will present with. So stage of tubal occlusion, that mucosa, it has become congested, edematous, hyperemic. So what will happen? It will lead to the Eustachian tube occlusion. The lumen will be occluded, and once the Eustachian tube is occluded, what will happen? The middle ear cavity could not be aerated, because this is the only path from where the atmospheric air can go into the middle ear cleft. So intratympanic pressure will decrease, and air, whatever will be present there, that will be absorbed. And we know that the volume of the middle ear cavity is very small. So once air is absorbed, there will be negative pressure in the middle ear cavity. So tympanic membrane will be retracted inwards. So if patient comes to you at this particular stage of tubal occlusion, he may complain of ear fullness, some hearing loss, even tinnitus, earache if it is there, it may be mild, and on examination there will be the signs of what we call as signs of tympanic membrane retraction, because inside the air has been absorbed, there is a vacuum inside, so tympanic membrane is retracted inwards. So what will happen, this handle of malleus, which is normally vertically placed, it becomes horizontal. When it becomes horizontal, because the tympanic membrane is pulled inwards, so when it becomes horizontal, it looks shortened. Actually it is not shortened, but when we look on otoscopy, it looks shortened. This cone of light, either it may be absent or it may be distorted, because the position of the tympanic membrane is changed by retraction. This lateral process of the malleus, it has become more prominent, with prominent anterior and posterior malleolar folds. And if child is responsive to, on tuning fork test, there will be conductive type of hearing loss. So this retraction, it is just like called, for example, this is the normal position of the tympanic membrane like this. What will happen with retraction? This handle of malleus is being retracted inwards. So now it is more horizontal, it looks shortened, and here anterior and posterior malleolar folds, they become prominent along with this lateral process of malleus. So this is what we call as a knuckle sign, just like a jab, knuckle sign it is called. Now this is the normal tympanic membrane. Now you can compare the two. On the left side is retracted one. Here you see handle of malleus is vertically placed, so it looks longer as compared to handle of malleus here on the left side, where it is shortened, more horizontal. This lateral process of malleus is not that much prominent. As you can see, it has become more prominent here. Here cone of light properly placed, here it is distorted, or even it may be completely absent. And anterior and malleolar folds you can see very prominent here in this retraction, while these are not that much prominent here in the normal position of the tympanic membrane. So this is the stage of tubal occlusion. Later on what will happen? That when there will be vacuum due to the absorption of the air, the lining mucosa of the middle ear cavity will try to occupy that space. So when mucosa will try to occupy that space, there will be engorgement or swelling of the mucous membrane. So, and the bacteria also have invaded till then. So there will be hyperemia, and then there will be increased secretions which will be transudate till this stage. And when transudate will be there and engorgement and hyperemia will be there, the tympanic membrane will become congested. So the patient will complain of now earache, because now the pressure is building up in the middle ear cavity. So earache will be there, hearing loss will be more marked, and because fluid is being formed, though still it is at the stage of transudate, but the pain character will be throbbing type. It will disturb the sleep, tinnitus will be there, and in children even high grade fever will be there. And on examination, the tympanic membrane, as I told you, due to increased hyperemia or vascular supply, its appearance will be just like a cartwheel appearance of the tympanic membrane. Just like a wheel of a bicycle or motorbike or a cart, it has got a hub in the center, and from there its spokes, they are radiating from that central hub. Similarly, if you see in this picture also, from the center the blood vessels, they are radiating towards the periphery, and the landmarks which were visible in previous stage, that is the stage of tubal occlusion, where we can see the handle of malleus, short process of malleus and malleolar folds. Here you cannot appreciate the handle of malleus, and blood vessels, they are radiating from the center towards the periphery. This is what it is called as cartwheel appearance of the tympanic membrane. If patient is not treated at that stage and all the pathophysiological features, they are not reversed back, or proper treatment is not being given, the disease will progress to next stage, more severe stage, which is a stage of suppuration. So as the name indicates, that transudate will be converted into a pus formation, that is the exudate. So when pus will be there, tympanic membrane will be, because volume of the fluid will be more now, and it will be pus inside the tympanic cavity, and we know that the tympanic cavity is very small, its volume is very limited. So when pressure is increasing, what will happen? The tympanic membrane will be bulging outwards towards the external auditory canal, and at the same time it will be compressed by that fluid, so there will be relatively ischemia of the tympanic membrane. It is bulging outwards. So where there will be maximum pressure or compression, from there the tympanic membrane will become yellow, and that yellow point is actually the impending perforation point, that if still at this particular disease the infection is not controlled, so pressure will remain increasing in size, and ultimately the tympanic membrane will give way at that particular point, which is more ischemic, and on otoscopy it is evident as a yellow point, with the rest of the tympanic membrane will be a bit congested. So that ischemia will lead to necrosis at a particular point. So now you can very well imagine that there will be excruciating pain, unbearable pain now. Hearing loss increased, high grade fever now, 102 to 103 degree Fahrenheit, with vomiting and even convulsions. Tenderness will be there over the mastoid antrum, and if you request for X-ray mastoid, there will be clouding of the air cells due to exudate on X-ray mastoid. And on otoscopy, you will see the bulging of the tympanic membrane towards you, and now congestion is not that much as it was there in the previous stage, and there may be a yellow point from where the tympanic membrane may be giving way later on. So bulging out the tympanic membrane and loss of anatomical landmarks on X-ray mastoid. There you can see this is the mastoid area. All there is clouding of the mastoid air cells. Normally the X-ray mastoid will look like that there will be honeycomb appearance. This is a normal mastoid air cells. Honeycomb mastoid air cells will be there in this particular area. Then is next stage is that stage of resolution. What is stage of resolution? Or you can say it may be a natural outcome of this disease, because the pressure inside was increasing, and as I told you, in a stage of suppuration, there will be ischemia of the tympanic membrane due to ischemic necrosis, which will be preceded by a yellow point over any part of the weakest part of the, you can say, of the tympanic membrane. So from where it will be a perforated, and once the tympanic membrane is perforated, there will be ear discharge, and immediately when ear discharge will start coming out from the external auditory canal, earache will be relieved immediately, because the pressure inside the tympanic cavity is relieved now, and at the same time general condition like fever that will settle down, and leukocytosis will start improving on complete blood examination. If the patient does not go into stage of resolution, or the organisms are more virulent and resistant and immunity of the patient is less, the disease can go into stage of complications. Stage of complications includes, as far as otitis media, there can be intratemporal, which are also called as extracranial complications, including acute mastoiditis. There can be facial paralysis. If infection is traveling towards the inner ear, there can be labyrinthitis, and along the skull base there can be petrositis. And if infection goes intracranially, because we know that the middle cranial fossa and posterior cranial fossa, they are in the vicinity of the tympanic cavity, there can be extradural, subdural, or brain abscess, meningitis, lateral sinus thrombophlebitis, or otic hydrocephalus can occur. In early 60s, 50s, when antibiotics were not there to help out, These complications were common with acute infections, whether this is acute otitis media or acute rhinosinusitis. But nowadays, these complications are more common with chronic suppurative otitis media and chronic rhinosinusitis as compared to acute infections. But still, we should keep in mind. Otherwise, in detail, we will talk about these complications when we will be discussing chronic suppurative otitis media. So treatment, of course, this is an infection, so we have to control the infection. And that infection will be controlled with the help of antibiotics, which can be intravenous, systemic antibiotics, then locally, if any treatment is required, and if there is some underlying disease, for example, adenotonsillitis, repeated adenotonsillitis is there, or there is allergy of the nose or paranasal sinuses, or there is some disease there in the nasopharynx. So we have to treat that underlying disease as well to avoid the relapse of a recurrent otitis media. So infection, what the antibiotics do? They arrest and reverse the inflammation. They prevent suppuration and perforation. They will relieve the symptoms and they will hasten the resolution and reduce the risk of complications. And as we have seen in the bacteriology, that Streptococcus pneumoniae and H. influenzae, they are mainly involved. So we can go for penicillin and its derivatives, that is ampicillin in the form of 50 milligram per kg per day in 4 divided doses, or amoxicillin in 3 divided doses, 40 milligram per kg per day can be used. Then at the stage of tubal occlusion and pre-suppuration, when perforation is not there, we have to relieve the earache and control the inflammation. So because there is tubal occlusion, so for that we can use the decongestant nasal drops. Mind you, we have to use nasal drops. Sometimes patient is astonished that I have come with earache and doctor is prescribing me nasal drops instead of ear drops. Because we have to understand the pathophysiology. Underlying is the eustachial tube dysfunction or eustachian tube blockage. So we have to try to open it. So we have to use decongestant nasal drops. Xylometazoline or oxymetazoline are commercially available. Even oral nasal decongestants, pseudoephedrine, can be used. And patient is having fever or pain, so we should go for paracetamol. Once perforation has occurred, so there will be ear discharge in the external auditory canal. We should do the ear toilet to remove all that, and we should try to control the infection with the antibiotics. And once the disease is under control and perforation remains there, then we have to think about to repair the tympanic membrane by laryngoplasty at a later stage. This is the universe. This is where we are. Still we think we are something. So just summarize the medical management: that systemic antibiotics, nasal decongestants, antihistamines, analgesics and antipyretics. Once the perforation is there, oral toilet, then hot fermentation for severe ache can be used, and we must review our patient after 48 hours. If after 48 hours still earache and fever persists, we have to change the antibiotic. And if the tympanic membrane is bulging and there is threatened perforation of the tympanic membrane, yellow point is there, so instead of waiting for spontaneous rupture of the tympanic membrane, we should go for a planned surgical incision of the tympanic membrane, which is called as laryngotomy, and the ear discharge should be sent for culture sensitivity. If after 48 hours earache and fever subside, we should continue with the same treatment for at least 2 weeks. Then after 3 months, the patient should be reviewed again. If there is no effusion, no further treatment is required. But if effusion persists, effusion means that the fluid from this exudate, again it has come to the stage of transudate, but it is not being drained, still it is there. So it means the sequelae of acute otitis media is now otitis media with effusion. So that is also a separated entity. So we should deal the patient as a case of otitis media with effusion after 3 months review. If there is involvement of the mastoid air cells, there is mastoid abscess or coalescent mastoiditis, then we should think about the cortical mastoidectomy. So if you think today's session was helpful for you, so please subscribe the channel and share it with your friends also. Any suggestions are welcome in the comment section. Thank you very much.